Okay, let's see ASCII questions from neurosurgery. So, regarding neurosurgery, the ASCII questions are very specific only. Okay, so I have developed a questions which is usually asked by the examiner. Okay, the basics questions. Okay, mainly they focus on the trauma, neuro-oncology, and pediatric neurosurgery. So, first we'll see about all the ASCII stations from the trauma. So, first question, the case scenario: a 23-year-old male presented to the emergency department, okay, with a history of RTA, and he secured a head injury with no history of LOC, and he had multiple episodes of vomiting and no seizure episodes. While examination, his GCS is 13. This is a simple case scenario. This is usually the patients come to the RTA with the head injury. So the basic questions by the examiner is, what is classification of head injury? First question. Second, how do you assess GCS, Glasgow Coma scale? Third, what is the next line of investigation, especially for the head injury? So, next, what is the indication for a CT brain in head injury patients? First, head injury classification. The head injury is classified into 4 grades. Okay, number 1 is minor, number 2 is mild, number 3 is moderate, number 4 is severe head injury. Okay. In case of minor, what is minor head injury? When the GCS of the patient is 15 with no LOC, it is called minor head injury. Okay. Whenever the GCS is 14 or 15 with the LOC, okay, the patient had loss of consciousness. With the GCS 14 or 15, this is called minor head injury. Okay. Next is moderate head injury. When the GCS is between 9 to 13, it's called moderate head injury. So, when we call the head injury as a severe, the GCS is 3 to 8, we call it as a severe head injury. The head injury is classified into 4 grades. One is minor, mild, moderate and severe. The severe head injury, the GCS is between 3 to 8. Okay. When the GCS is less than 8, that is also indication for the intubation. Second question, how do we assess Glasgow Coma scale? That is GCS. As everyone knows, GCS has 3 components: eye opening, verbal response and the motor response. In the eye opening, the highest score is 4. In the verbal response, the highest score is 5, and the motor response highest score is 6. So, let us come to eye opening. Whenever the patient come to the casualty, mainly you have to assess the GCS. Okay, this is a primary survey. The GCS comes under the primary survey. So, in the components of GCS, first component is eye opening. You assess the opening of the eyes, how the patient open his eyes. Okay. So, first, suppose the patient opened the eyes spontaneously, means the score is 4. The patient opens eyes only to the verbal commands, that is means the score is 3. Okay. The patient opens eyes to the painful stimulus, means the score is 2, and the patient does not open the eyes, that means the score is 1. So, verbal response. Let us come to the verbal response. So, suppose you ask the patient some questions. Okay, what is your name? Okay, the patient normally respond to that question, means his verbal response is normal, that is 5. Suppose he is telling something different. Okay, he is confused. Suppose you are asking what is your name, but he is telling that he is I am coming from Chennai. So, he is confused. Okay, that means confused. Suppose he giving some inappropriate word only. Okay, inappropriate or word only. Okay, the same question, what is your name? Suppose he is telling I had my food. Okay, inappropriate words. The inappropriate, or he is giving some words only. Okay, and the next is giving, when you are asking some question, he is giving some sounds. Okay, sound means is screaming. Ah, oh, like that he is telling. Okay, ayo, that is telling is sounds only. So, that sound is coming in, give the scores 2, and no sounds means the score is 1. Okay. Suppose the patient is intubated, the score is belong to T. Okay. Then comes to the motor response. Okay. Suppose the patient obeys the commands and he is doing the motor activity what you are telling. Okay. Suppose you say the patient to raise the hand. Okay. He is raising his hand and he is obeying your command. That means that his score is 6. Okay, complete score is 6. He is not obeying, but his localizes to the pain is 5, and his withdrawal or flexion. Okay, suppose you are giving some pain response, he is flexing his arms. Okay, flexing his arms and his legs also. Okay, so overall flexion. Okay, or he is giving some withdrawal. Okay, that means that his score is 4. So what is score 3 is abnormal flexion. So the abnormal flexion is when you are giving some pain stimulus, he is flexing only the upper limb, his lower limb is extended. Okay, or his lower limb is flexed or upper limb is extended. This is called abnormal flexion. This abnormal flexion belongs to score 3. Okay, and extension is 2. Okay, and so your extension is called decerebrate. Decerebrate rigidity, and flexion is called decorticate. Okay, so it's called a decorticate. So extension is called decerebrate rigidity, and is not showing any motor responses. The score is 1. Okay, so the highest score of the GCS is 15. Okay, that's you have to know. The 15 means the patient is normal, GCS 15. Okay, among the 3 components, which component is very important means the motor component is very important. Next, what is the next line of investigation you have to do? So you have to take whole body CT brain as usual, depending upon the institutional protocols. Some institutions they will take whole body CT, especially CT brain is very important, and the CT neck, CT facial bones if indicated, and the CT chest and the CT abdomen. And some institutions they will take wherever the injury is there, but CT brain is very important, followed by they will take chest, ultrasound fast they will do, and they will, if indicated, they will do CT brain. So the next line of mandatory investigation for the head injury patient is NCCT brain. Okay, so next, what are the indication for CT scan in head injury patients? Okay, whether all the patient with head injury need a CT scan? No, there is a separate guidelines for the indication for CT scan in head injury patients. That guideline is called NICE guideline. Okay. So what is the indication for CT scan in within 1 hour? When the patient is coming to a casualty, he have to take the CT scan within 1 hour of the presentation. Okay, when all the indications for the all following indication, that is GCS, if the patient GCS is less than 13 at any point, or patient GCS is less than 15 at 2 hours. Okay, or focal neurological deficit, the patient has focal neurological deficit, or suspected open, depressed or basal skull fractures. Okay, whenever you are suspecting open, depressed or basal skull fractures, you have to take CT brain, or more than 1 episodes of vomiting and post-traumatic seizure. Okay, these are the indication where you have to take the CT brain immediately, that is within 1 hour of the presentation. So again I am telling, so GCS less than 13 at any point, and GCS less than 15 at 2 hours of the presentation, or focal neurological deficit, suspected skull bone fractures, okay, either open or depressed or base of the skull fractures, okay, or more than 1 episodes of vomiting and a post-traumatic seizure. Okay, these are the indications where you have to take the CT scan within 1 hour, and where the indication for CT imaging within 8 hours of the presentation. So whenever the patient age is more than 65 and the patient is having any coagulopathy disorder, that is he is on aspirin or warfarin or some antiplatelets like rivaroxaban uses, you have to take CT brain. Is very essential because it may hide the interior skull bleed. Okay, dangerous mechanisms of injury like fall from height, RTA, or retrograde amnesia. When the patient having retrograde amnesia more than 30 minutes, that's also indication for a CT brain. Okay, these are the overall indications for the CT brain when you have to take the CT brain within 1 hour, or whenever the CT within 8 hours. Okay, so Within 1 hour, you have to take, whether the GCS is less than 13 at any point, you have to take CT scan, and the GCS is less than 15 by at 2 hours. Okay, whenever you are suspecting skull bone fractures, whenever the patient having more than 1 episodes of vomiting and a post-traumatic seizure and a focal neurological deficit, you have to take CT scan within 1 hour. Whenever you have to take CT scan more than 8 hours, within 8 hours means whenever the patient having age more than 65, and when the patient is taking any coagulopathy disorders, like he is taking warfarin, rivaroxaban, like anticoagulants is seeing, suppose he is taking any anticoagulants, you have to take CT scan within 8 hours, or any dangerous mechanism of injuries or retrograde amnesia more than 30 minutes. So next question, suppose the same head injury patient, okay, he is having GCS is very poor, okay, he is having severe head injury, and he is admitted in ICU, suppose. Okay. So, what are the key parameters to maintain in the ICU, especially in neurosurgical ICU? And what are the various measures to reduce the intracranial pressure? And what are the outcome scale of the head injury patients? Okay, how to assess the outcome scale? Okay, these are the questions. So, this is your ICP waveforms. Okay, so these are the ICP waveforms of the normal P1, P2 and P3. Okay, in case of head injury patients, where P2 will be prominent, okay, compared to the other two waves P1, P2. Okay, so compared to P1, P3, the P2 will be prominent in case of head injury patients. Okay, just try to remember. So the P2, it indicates the complaints of the brain. Okay, whenever there is a ICP is raised, the P2 will be prominent. So what are the various measures to reduce ICP? Okay, so number one, simple measures like elevation of the head of the bed to 30 degrees. Okay, so that is indicated in all patients. Okay, whatever the patient head injury, if you elevate the head to 30 degree, it's a simple measure to reduce the ICP. Okay, and remove cervical spine collar. Okay, okay, it should be removed in all patients except in the patient where you are suspecting cervical spine fractures. Okay, in cervical spine fractures, you should not reduce the cervical spine collar. Okay, that we all know already. Number two is sedation. Okay, so sedate the patient using propofol. Okay, so when you have to use this propofol, it's reserved for the patient in ICU with the secured airway. Okay, and the patients with an unsecured airway and neurological deterioration require and rapid anesthetic review. Okay, suppose hypotension develops, use midazolam. Okay, so you have to use the propofol. Is typically 1 milligram per kilogram bolus. Okay, and you have to titrate according to the response. Okay, it should be used in ICU with the secured airway, and also in unsecured airway and neurological deterioration when you are going for rapid sequence induction. Okay, suppose the patient develops hypotension due to propofol, use midazolam. And proper analgesia you have to give. Okay, so the main drug used in the ICU is fentanyl. Okay, and the same fentanyl you have to use and titrate according to the response. Dosage is from 1 to 4 microgram per kilogram per hour. It starts as infusion, and it is reserved for patient in ICU with the same security airway, and also the patient with unsecured airway with neurological deterioration using rapid sequence induction. Fourth is paralysis. So you have to use the paralytic agents like atracurium or other neuromuscular blocking agents. Okay, and you have to start as infusion 0.5 milligram per kilogram per hour, and it is same reserved for patient in ICU with the secured airway, and the patient with unsecured airway and the neurological deterioration requires rapid anesthetic review. Okay. Fifth is hyperosmolar therapy. So the hyperosmolar therapy consists of two drugs. One is mannitol, SSL 20% mannitol, and a hypertonic saline 5%. Okay. The other strength are also available, that is 3 to 23%. In routinely practice we are using 3% NS. Okay, 3% normal saline, okay, 3%, that is 3% NaCl, okay. So that is hypertonic saline. In routine practice we are using, okay. This is the hyperosmolar therapy. So mannitol 20%, okay, you have to start as 0.25 gram per kilogram or to 1 gram per kilogram, okay. So dose of the mannitol, okay, so mannitol 20%, okay. So you have to start as a resident, general surgery resident, you should know the dosage of the mannitol, okay, because the mannitol is commonly used drugs in a neurosurgical ICU also, and also in emergency casualty also. So you should know the dosage of the mannitol is 0.25 gram per kilogram of the body weight to 1 gram per kilogram of the body weight, okay. This was especially if suppose the patient is having 70 kilogram, you have to use 88 to 350 ml of mannitol, hypertonic saline, okay. Where it is mannitol is indicated? So indicated in the neurologically deteriorated patients. Whenever there is a drop in GCS score, the patient having anasechoria after trauma. So all patients with newly diagnosed traumatic SYL who require surgical treatment, okay, or whenever there is a raised ICP more than 20 millimeter of mercury, okay. So the three indications: whenever the patient having neurological deterioration, so all patients with newly diagnosed traumatic SYL, okay, who require surgical treatment or raised ICP more than 20 millimeter of mercury, okay. So where the mannitol is contraindicated, suppose the patient is already known, okay, is already known, we have known the diagnosis that the patient is having EDH, okay. In EDH you should avoid mannitol, okay, because it will progress the EDH, okay. So hypertonic saline, that is 3% NS, is used in the rate of 2 ml per kilogram of body weight, okay. Suppose 70 kg patients, you have to use the 150 ml, okay, 150 ml maximum we can use, okay, for 70 kilogram patients, okay. So indication is the neurological deterioration same after a trauma, or all patients with the newly diagnosed traumatic SYL who require surgical treatment, okay, and is giving some extra hyperosmolar therapy, okay, extra anti-edematous effect apart from mannitol, and wherever the mannitol is contraindicated, we can use this 3% as also, okay. We should not give if sodium is more than 155, okay. Suppose so in a hypernatremia, very high hypernatremia, you should not use the 3% NS, okay, and it's also indicated in whenever there is a raised ICP more than 20 millimeter of mercury, okay. Next, your hyperventilation. So the hyperventilation the same, okay. So you have to make the patient ventilate hyper by making changes in the ventilatory settings, okay. So the dosage you have to decrease the PCO2, okay, less than 25 to 30 millimeter of mercury, okay. So it indicated in neurologically deteriorated patients after trauma. It acts only as a bridge therapy to transfer the patient for definitive treatment, okay. So it's only a bridge therapy only, it's not definitive therapy, and it should be avoided, okay, in first 24 hours of injury, okay. So what we have seen to various ways to reduce the ICP. Number one is a simple measure. So elevate the head of the bed to 30 degree and remove the cervical spine collar and use sedations, okay, like propofol and analgesia like fentanyl infusion, and give paralytic agents to the patients, and start an hyperosmolar therapy like 20% mannitol or 3% NS, and hyperventilate the patients. So these are the various methods to reduce the ICP. Okay. So the first line ICP control involves optimizing sedation, so ventilation, and check serum sodium levels, okay. So you can use a bolus of mannitol or hypertonic saline. So ICP monitoring is important, okay. So in case of very high raised ICP, you can remove some part of CSF using EVD. That is also decrease ICP. So raising of the head, loosening the collar, and a seizure and pyrexia should be controlled, okay. So you should start on the patient with anti-seizure medications, okay, like injection phenytoin, like injection levetiracetam, like you have to start the patient to prevent the seizure, because seizure will increase the ICP. Okay, and escalating the dose of sedative, analgesia and muscle relaxants. If all these patients male, you have to increase the dosage of the mannitol or hypertonic saline. Okay, finally, if all the measures are failed, you can use induction of therapeutic hypothermia or thiopentine coma. Okay, and finally, surgical decompressive craniectomy. Okay, so in the meantime, you have to check the pituitary functions. So consider seizure prophylaxis. Okay, and enteral nutrition within 72 hours. And one main thing is you should avoid steroids. Okay, the steroids is completely contraindicated in severe head injury, and it increases the mortality and it is not recommended. Okay, and the steroid is contraindicated in head injury patients. So the various methods to reduce the ICP. Number one is simple measures like elevate the head of the bed and remove the cervical spine collar, sedations like propofol, analgesia like fentanyl, paralytic agents, and hyperosmolar therapy mannitol, and hyperventilation. So how to assess the outcome of the patient who undergone the treatment from head injury? Okay, so using the Glasgow outcome scale. Okay, so it's giving 5 grades. Okay, so the patient having good recovery, the score is 5. He is having moderate disability, score is 4. The severe, score is 3. The patient belongs to persistent vegetative state, the score is 2. And he is dead, the score is 1. Okay, these are the various outcome scales. Okay, mainly are following a Glasgow outcome scale when the patient is recovered from head injury. Okay, or getting treatment from head injury. Okay, we are using the scale Glasgow outcome scale. Okay, so good is 5, moderate is 4, severe is 3, and the persistent vegetative state is 2, and the dead, suppose the patient is dead, the score is 1. Okay, so let's see the various CT finding of the patient. Suppose the patient came to the casualty. Okay, you have resuscitated the patient. Okay, and you have taken the CT brain. So the CT brain, let's analyze the various CT findings and what are the things to do after that. Okay, for that CT findings. Okay, first, suppose the patient CT shows like this. Okay, so the patient CT shows like this. What is this? Okay, so this is a plain CT scan of the head. Okay, skull bone, and it's showing the fracture. Okay, okay, what is the diagnosis? What are the various treatment options for the skull bone fractures? Okay, so first diagnosis, the patient is having skull fractures. Okay, that's the diagnosis. So suppose where are the various treatment options for various skull fractures? Suppose the patient is having only closed linear fracture, you can treat it as a conservatively. Okay, suppose the patient is having open or comminuted fracture, you have to, the open wound should need the debridement. Okay, with the prophylactic antibiotic therapy. Okay, and you have to remove the fracture segment. Suppose the patient having depressed skull bone fractures. Okay, that depression skull bone is, suppose it is at least goes behind the thickness of the skull wall. Okay, number 1, or it having dural breach. Okay, the dura is teared. Okay, or it went below the thickness of the skull bone. That means that you have to elevate the bone. Okay, elevate that bone. Okay, if suppose not able to elevate, you have to remove the fracture segment. Second, suppose the fracture that involves the air sinuses. Okay, you have to manage it like open fracture. You have to do the debridement. Okay, using broad spectrum or without exploration. So these are various scenarios for skull bone fractures. What you have to use for closed fracture and open fracture. Okay, and depressed fracture. So indication for surgery in case of depressed fracture is whenever the depression of the skull fractured segment is below the thickness, okay, of the skull bone, you have to address, and whenever the dura is breached, you have to do the surgery. Okay, and you have to remove the fracture segment or you used to elevate. Okay, whenever the fracture segment involves the air sinus, you have to treat it like a open fracture. Okay, you have to do the debridement. Okay, and use heavy antibiotics, highly specific antibiotics. Okay, and the removal of the fracture segment. This is the first scenario. Suppose a scenario, the same patient, the CT scan shows like this. Okay, so what is the diagnosis of this patient? Okay, okay. The CT scan shows lenticular shaped, lens shaped. Okay, okay. Biconvex shaped, hyperdense lesion. Okay. So what is the diagnosis and what is the treatment of choice for this patient? So what is the indication for surgery if the patient comes to you, okay, in the emergency with this type of scan? Okay. So the lenticular shaped hyperdense lesion, the mass effect, the patient is having mass effect and with the midline shift. Okay. The diagnosis acute extradural hemorrhage. Okay. Acute extradural hemorrhage. The treatment of choice. Okay. Since the patient is having presented with the mass effect and a midline shift also, okay, you have to immediately do emergency procedure. It is a very urgent emergency, the acute EDH. Okay, you have to do emergency craniotomy and evacuation of the hematoma. Okay, so as soon as possible the patient is presented to you. Okay, it's very important. Okay, because why the indication for the surgery, okay, is suppose the volume is more than 30. Okay, you have to assess the volume of that EDH, okay, by using the scale that is given in the CT scan. Okay, a separate formula for assessing the volume of the, okay, EDH. Suppose the volume is more than 30 ml, you should not see the GCS score. Okay, you have to take the patient to the OT and you have to do the surgery immediately. Okay, regardless of GCS score, volume is 30. Okay, suppose if the patient GCS is less than 9, okay, and his thickness is more than 15 mm, okay, and his midline shift is more than 5 mm, that time also you have to do for surgery. Okay, so only two indications of surgery for EDH. Whenever you see the volume is more than 30 ml, you should not see the GCS. Okay, you immediately take the patient to the operation theatre and you have to do the emergency craniotomy and evacuation of hematoma. Okay, suppose, okay, the volume is very small. You are looking, the volume is very small. Then you have to see the GCS. Suppose GCS is less than 9. Okay, GCS is less than 9. You have to see the thickness and the midline shift also. The thickness of the hematoma is 15, more than 15 mm, and this midline shift is also more than 5 mm. You have to take the patient for surgery. Okay, these are the two indications for acute EDH. Suppose the next scenario, okay, the patient is coming like this, the CT scan is coming like this, and it shows, okay, concavo-convex. Okay, it's a semilunar type shape. Okay, hyperdense lesion that's shown in the CT scan of head injury patient, and it also shows a progressive midline shift. Okay, midline shift. Okay, the midline is shifted. Okay, and this cistern also effaced, sulcic area also effaced. Okay, the patient is having raised intracranial pressure, it shows. Okay, so what is the diagnosis in this patient? Okay, whenever you see a concavo-convex shaped hyperdense lesion in the CT, the diagnosis, what is the diagnosis, what is the treatment of choice, and what is the indication for surgery. Okay, so the diagnosis is acute STH. Okay, the patient is having subdural hematoma, and the treatment of choice is you have to do emergency craniectomy. Okay, you remove the bone flap. Okay, and you have to do the evacuation of the hematoma. Okay, so wherever the hematoma is there, you have to evacuate. Okay, by what means you are doing is different thing. Okay, okay, so emergency craniectomy you have to do with the evacuation hematoma to reduce the ICP. Okay, so what are the various indication for surgery? Okay, whether all the patients with the acute STH need surgery? No, there is specific indication for surgery in a patient with acute STH. Okay, so suppose the patient, the thickness of the hematoma is more than 10 mm, okay, or the midline shift is more than 5 mm, you should not see the GCS. Okay, that patient is taken for surgery. So regardless of GCS score, whenever there is thickness is more than 10 mm or the midline shift is more than 5 mm are taken for surgery. Suppose the GCS drop, patient having drop in the GCS while compared to the presentation. Okay, while receiving, you check the patient, the GCS of the patient was 14. After 2 or 3 hours, if suppose you check the patient GCS, suppose it should be less than 10. Okay, there is a drop in the GCS, or whenever the patient is having anisocoria. Okay, okay. So what is anisocoria? Okay, so the abnormalities of the pupil size. Okay, so one pupil will be in the normal and another pupil will be abnormal. Okay, the variations in the size between the two pupil, it's called anisocoria. So that all indicates that the herniation that has happened. Okay, so now GCS score drops and the anisocoria or ICP more than 20 millimeter of mercury. Okay, in that case, when the even if thickness is less than 10 or MLS is less than 5, you have to go for surgery. Okay, understood? So regardless of the GCS score, if the thickness is more than 10 mm or the midline shift is more than 5 mm, indicated for surgery. Whenever the patient GCS drops or anisocoria or the patient's ICP is more than 20 millimeter of mercury, okay, even if the thickness, okay, less than 10 mm or midline shift is less than 5 mm, you have to take the patient for surgery. So next, come to the next scenario. Suppose the patient CT scan shows like this. Okay, okay, a homogeneous hyperdense lesion that's present in the temporal lobe. Okay, so what is the diagnosis? What is the treatment of choice? What is the indication of surgery? Okay, let's see. Okay, what is the diagnosis of this patient? So it is left temporal ICH. Okay, intracranial hematoma. Okay, this is called intraparenchymal hematoma. Okay, so before going for the treatment choice for this patient, you should know what are the indication for surgery in case of intracranial hematoma, especially traumatic intracranial hematoma. Okay, so the indication of surgery is whenever there is a sign of clinical deterioration or a refractory ICP or mass effect on the CT. Okay, you should see these things. Whenever the patient clinical deterioration, that means whenever there is a drop in GCS or anisocoria present, or the patient ICP is refractory to the medical management. Okay, whatever we have seen before. Okay, the patient's ICP is not able to reduce by medical management. Number 3 is mass effect on the CT, you have to go for surgery. Number 2 is whenever the patient with the GCS score is 6 to 8 with the frontal or temporal contusion more than 20 mm and the midline shift of more than 5 mm. Okay, so whenever the GCS is 6 to 8 or the frontal or temporal contusion more than 20 mm with the midline shift more than 5 mm. Okay, or whenever there is a cisternal compression. Okay, okay, there is a compressions of the cisterns. Okay, especially the basal cisterns is compressed. You have to address it as the patient is having a raised ICP. Okay, so now GCS score is less than 8, that is 6 to 8 with the frontal or temporal contusion with the more than volume is more than 20 ml. Okay, with the midline shift is more than 5 mm or cisternal compressions, or whenever the GCS score is 6 to 8 with the contusion more than 50 ml itself. Okay, you have to take the patient for surgery. Okay, so these are the various indications for surgery. Whenever there is a signs of clinical deterioration or raised ICP or mass effect on the CT, taken the patient for surgery. Next indication is the GCS score is whenever the patient is assessing the GCS score, the GCS score is 6 to 8. At the time, you have to see the site of the contusion, whether the frontal or temporal. Even if it is less than 20 itself, you have to take for surgery. Okay, even the patient with the frontal temporal contusion with more than 20 ml and also midline shift of more than 5 mm, you have taken for surgery, or whenever there is a cisternal compression. When the patient GCS score is 68 with the contusion more than 50 ml is also indication for surgery in temporal ICH. The next scenario, in the CT scan, the CT scan shows only a punctate, okay, the punctate hypertension or simple punctate hypertension lesion, especially I have seen in the gray matter and white matter region, okay, junction of gray matter and white matter, okay. This is a junction of gray matter and white matter, especially you see a punctate contusion, the white matter gray matter junction, okay. As you know, you people are knowing the diagnosis, okay. What is the diagnosis? So what is the mechanism of the shearing force between the gray matter and white matter following injury is called diffusion axon injury. DAI, okay. So what is the investigation of choice for DAI is MRI brain, okay. It will not be depicted by a CT scan. The main investigation of choice for the diffusion axon injury is MRI brain. And what are the classification of DAI? Okay. So diagnosis is diffuse axonal injury. The investigation of choice is MRI. Okay. The same CT scan of the patient's MRI shows. Okay. So the following lesions. This is the classification of diffusion axonal injury. You are having 3 grades: grade 1 and 2 and 3. What is grade 1? Axonal injury of the parasagittal white matter of cerebral hemisphere, okay. It is only present in the white matter, okay. Grade 2 is grade 1 with focal lesion in the corpus callosum, okay. What is grade 3? The grade 2 with lesion in the cerebral peduncle, okay. These are the 3 grades. Grade 1, okay, axonal injury in the parasagittal white matter. Number 2, for grade 1 with the focal lesion in the corpus callosum, and the 3 is grade 2 with the focal lesion in the cerebral peduncle. These are the 3 grades of the diffusion axonal injury. So the next scenario, okay, is not acute trauma, okay. This scenario, the patient may have a previous trivial trauma, okay, and multiple repeated falls previously, this type of patients, okay, or he may have taken on any anticoagulant drugs, okay. The patient with the coronary artery disease, usually they will take aspirin, croplet, okay. Suppose they have undergone multiple falls before, okay. Suddenly the patient fall on the bathroom or fell from the bed, they immediately come to the casualty with the loss of consciousness or neurological deficits like weakness of the limbs, okay. By the time if you are taking CT, it shows like this, okay. So what is this lesion? Okay, it shows a similar iso to hypodense lesion, okay, hypodense lesion in the convexity, okay. So what is it indicates? So what is it shows? It's not very hyperdense, okay. It is a hypo to isodense, okay. That indicates that. What is the diagnosis? What is the treatment of choice? So it indicates your chronic STH. Okay. So there are various types of chronic STH available, okay. So what is the treatment of choice for the chronic STH? Burr hole and evacuation of the hematoma. So you have to try with the burr hole, okay. Suppose the hematoma is not to be evacuated adequately, you have to go for the craniotomy. Craniotomy followed by evacuation of hematoma, okay. Okay. So what is the main reason that the patient is having this type of not able to retrieve all the hematoma is the presence of the membranal bleed. Due to membrane bleed which consists of the hematoma, okay. So suppose the patient hematoma is not to be evacuated with the burr hole, you have to choose craniotomy and evacuation of the hematoma. Okay, these are the various scenarios that we can see in the adult patients, okay. So we have seen acute EDH, acute STH, okay, and on intracranial hematoma and diffuse axonal injury and chronic STH. Okay, these are the various presentations we have seen in emergency with the trauma patients. Okay, next we go to the some pediatric trauma. Okay, suppose the pediatric child, 4-month-old baby, okay, brought by the parents to the ED, okay, following a fall from cradle with a history of vomiting. Okay, the history of vomiting is there. On examination, the baby opening the eyes, okay, and it cries and withdraws the limb in response only to the pain. Okay, okay, the baby open eyes, cries and withdraws only to the pain. Okay, and we have noticed multiple contusions present over the body of the baby. Okay, so this is a scenario that is given to you. So they will acquire your clinical knowledge in this ASCII. You are asking certain questions. So how to assess pediatric GCS? What is the next step for this patient? So what is the indication for CT brain in pediatric pupils? Okay, first we'll see about the pediatric GCS assessment. Okay, like adult, the pediatric also having 3 components: eye opening, verbal response and motor response. Okay, so the maximum score is 15 only, like in the adult. And the eye opening, the maximum score is 4, and the verbal response, the maximum score is 5, and the motor response, the maximum score is 6. Okay, so the eye opening is similar to the adult. Okay, okay, whenever the child spontaneously open the eyes, that is score is 4, and whenever the eyes opens to verbal stimulus, the score is 3. Whenever the eyes opens to the pain, okay, the score is 2, and whenever there is no response, the score is 1. Okay, the verbal response. Okay, so verbal response is slightly different from the adult people. Why? Because the child and the pediatrics babies usually won't talk. Okay, so we can't able to acquire the verbal response. Okay, so that they are given that certain formulation for the child, that whenever the baby coos, giving a coos sound, okay, that is score is 5. Okay, suppose the child is irritable cries. Child have irritable cries means the score is 4. Okay, suppose the baby cries only in response to the pain, that means that the score is 3, and it only moans in response to pain, that is score is 2. Whenever there is no response, the score is 1. Okay, and the motor response. Okay, whenever the baby spontaneously moves the limbs, okay, is spontaneously moving or playing, okay, with these 4 limbs, means the score is 6. Complete score is 6. And the baby withdraws to the touch. Okay, whenever you touch the baby, it suddenly withdraws. Okay, that means that the score is 5. Withdraws to the pain, the score is 4. Okay, next, the score 3 is whenever there is flexus to the pain, like in the adult. Okay, whenever it extends to the pain, the score is 2. No response is 1. Okay, like decorticate, decerebrate in the adult. Okay, so the difference from the adult GCS is all verbal responses are different, and score 5, 4 of the motor response is different from the adult. Okay, once again I'm telling, the verbal response when the babies coos or babbles spontaneously. Okay, it means that the full score 5, and the irritable cry, the baby is having irritable cries, that is score is 4, and cries in response to pain, the score is 3, and moans in response to pain is score 2, and no response is 1. For the motor response, whenever the child having playful activities, his plays itself, spontaneous movements are there, the score is 6. When it withdraws to the touch, okay, the score is 5. When it withdraws to the pain, the score is 4. The flexus to the pain, the score is 3. And the extends to the pain, score is 2. And there is no response, score is 1. So the next, what is the indication for a CT scan following head injury in the pediatric patients? Okay. Number 1 is suspicion of non-accidental injury. That is NAI. Whenever you are suspecting the non-accidental injury, you have to take a CT. It's very important. And he is having medical legal issues also. And when the patient is having a seizure in the first seizure episode itself, you have to take the CT. Whenever the GCS is less than 14 or less than 15 in under ones. Whenever the GCS is less than 15 in 2 hours post injury. Next is signs of fracture of the base of the skull. Whenever you have a focal neurological deficit, whenever you have a bruise or swelling, laceration more than 5 centimeter, in under ones, more than 5 centimeter, whenever you see the bruise or laceration or swelling, whenever you have seen more than 1 of LOC for more than 5 minutes, abnormal drowsiness or 4 or more episodes of vomiting. In adult, more than 1 episodes of vomiting, you are taking CT. But in child, whenever you are seeing 4 or more episodes of vomiting, then you have considered CT scan. Or dangerous mechanism of injury or amnesia more than 5 minutes. In adult, you have to take amnesia more than 30 minutes. You have to go for the retrograde amnesia of more than 30 minutes. You have taken for CT scan. But in case of pediatric, you have to taken whenever there is amnesia more than 5 minutes. So the various indication for CT scan in pediatric child is whenever you suspect non-accidental injury, and the first seizure episode itself in under 1 year of age, whenever GCS is less than 14 or less than 15, is taken for CT. And whenever the patient GCS less than 15 in 2 hours post injury, whenever you are finding a signs of fracture of skull bone fractures, focal neurological deficits, whenever seen bruise or swelling or laceration which is more than 5 centimeter, and when you have seen more than any one of LOC, suppose LOC more than 5 minutes or amnesia more than 5 minutes or abnormal drowsiness, 4 or more episodes of vomiting or dangerous mechanisms, you are taken for CT scan. So next to ask you question, a 65-year-old male, presented to the neurosurgery OPD with the complaints of gait disturbances, in the form of short shuffling gait, and urinary incontinence, for 2 months. And the CT brain shows the following features. So what is the diagnosis? Triad, differential diagnosis, genes associated with it, and management. So what are the various things? So first, what is the CT scan source? So the CT scan shows the ventriculomegaly. The ventricles is enlarged so much, and this you see the angle between the callosal, corpus callosal angle is decreased so much. So even though the ventricle is enlarged, it is the sulci and the gyri is not closed. That is called DESH. Disproportionately enlarged subarachnoid space. So let's see what is the diagnosis of this patient. This is a short shuffling gait. This is also called magnetic gait and bradykinetic gait and short-stepped gait. There is various names for this gait. The patients walk like this. And the diagnosis of the patient is normal pressure hydrocephalus. So normal pressure hydrocephalus. And what is the triad? The triad is, the mnemonic is GUD. Gait disturbances, urinary incontinence, D is dementia. And what are the various DDs? Alzheimer's disease, Parkinson's disease, and vasculitis disease. In CNS vasculitis, the patients also presents like this, the various differential diagnosis. And the mainstay treatment of the patient is VP shunt. So this is disproportionately enlarged subarachnoid space hydrocephalus, that is called DESH. Okay. So you have see the ventricles are enlarged, but the Sylvian fissure showing narrow sulci. Okay, the Sylvian fissure shows the narrow sulci. Okay, so normally, okay, the callosal angle. This is the angle between the corpus callosum. The corpus callosum angle should be more than 90. If it is less than 90 degrees Celsius, it is consistent with the normal pressure hydrocephalus. There are various risk factors for the normal pressure hydrocephalus, that is age, diabetes, hypertension, hypercholesterolemia and alcohol use, and symptoms like this are triad, gait disturbances, incontinence and altered menstrual state. These are signs that enlarged ventricles, increased intracranial pulsation, increased amplitude of intracranial pulsation, ICP waveforms is increased, and CSF stasis and cerebrovascular changes. These are the various signs. Okay, the triad is very important. Okay. What are the various differential diagnoses of this patient? In these cases, in seeing the neurodegenerative diseases like Alzheimer's disease, Parkinson's disease, Lewy body diseases, and in case of vascular dementia, okay, in case of CVA, the patient also presents like this, and either hydrocephalic disorders like acute stenosis, infectious diseases like Lyme's, HIV and syphilis, CNS HIV also present like this, and urological disorders, UTI, bladder or prostate cancer, miscellaneous like vitamin B12 deficiency. So there is a wide variety of differential diagnosis for this NPH. So we have to address the patient carefully and we have to do the surgery of VP shunt. Okay. So what are the various genes involved? Okay. So number one is NME8 gene. Okay. So second is CFAP43, and third is SFMBT1. Okay. These are the three genes that is specific for normal pressure hydrocephalus. Number one is NME8, number two is CFAP43, number three is SMFBT1. Okay. So how will you approach? Okay, how will you approach normal pressure hydrocephalus? The patient present with ventriculomegaly, okay, gait dysfunction, urinary urgency, with incontinence without cognitive impairment. Okay, so you have to rule out any other cause of gait dysfunction present or not. Okay, if it is present, okay, you have to rule out the differential diagnosis like Parkinson's disease, cervical myelopathy, vitamin deficiency or hypothyroidism. Okay, if the other causes are not able to find, that means you have to do MRI finding suggestive of NPH. Okay, suppose MRI finding suggestive of NPH, okay, or not. If it is suggestive, you can go for high volume LP or lumbar drain trial. Okay, and while doing lumbar puncture, okay, you have to see the opening pressure. Okay, if it is a pressure more than 25 centimeter of water or CSF shows pleocytosis, you have to investigation for other cause of high ICP. Okay, because the opening pressure is very high, that means that the patient is having increased intracranial pressure. Okay, but we are seeing about normal pressure hydrocephalus. In that, the CSF pressure will be normal. If suppose the pressure is not that much raised, open pressure is not that much raised, means, okay, you have to clear clinical response to CSF removal. You have to see whether the patient having symptom relief from the CSF relief. Okay, so you are taking CSF from the LP, you have to check the patient's response following the CSF removal by via lumbar puncture. Okay, if it is there, symptom response is there, then it is NPH, you have to go for VP shunt. Okay, if it is not there, it will be NPH less likely. If the clinical suspicion is very high, suppose you are suspecting this definitely clinically suspect to be NPH, then you have to go for VP shunt. Suppose MRI finding itself not suggestive of NPH, and you also ruled out other differential diagnosis. That means that you have to consider it as either SVACO hydrocephalus or consider a neuropsychological testing for neurodegenerative diseases. Okay, or you are still suspecting, even if the MRI is negative, you are still suspecting clinically it is to be NPH, you have to go for high volume LP or lumbar drain. Okay, So clear clinical response for the CSF removal is present, means that it is definitely NPH. You have to go for LP, VP shunt. Okay. If NPH is less likely, but clinically you are suspecting it, means you have to go for VP shunt. Okay. Okay. At the end of the result, the treatment of choice for NPH is VP shunt. Okay. These are the approaches to the NPH in clinical scenarios. So the patient will having a short shuffling gait, magnetic gait. The triad is a gait disturbances, urinary incontinence and dementia. Okay. MRI finding shows a DSH, okay, disproportionately enlarged subarachnoid space, hydrocephalus, and callosal angle will be less than 90 degree. Okay, what are the various risk factors? What are the differential diagnoses? Okay, especially Alzheimer's, Parkinson's, Lewy body diseases, and CNS vasculitis, and infective causes like HIV, syphilis, and genes involved in the normal hydrocephalus, and various treatment algorithm for NPH. 30-year-old obese female patient presented with a severe headache and visual deterioration. An examination of the eye shows papilledema. The MRI shows the following features. Okay. So what is MRI? So typically look into this MRI. Okay. You have see the retinal fibers. Okay. Retina and the optic nerve tortuosity is seen. Okay. So what is the diagnosis? It's indicative of idiopathic intracranial hypertension. Okay. So what is the investigations and medical management and surgical management for these cases? The diagnosis is idiopathic intracranial hypertension. The various investigations in MRI, you look for a finding of dilated CSS space around the optic nerve and empty cella and dilated Meckel's cave. So where you have seen this is a dilated CSS space around optic nerve. Okay. These are the dilated CSS space around the optic nerve. Okay. And the empty cella. Okay. And the dilated Meckel's cave. Okay. These are the findings suggestive of idiopathic intracranial hypertension. And while doing lumbar puncture, the opening pressure should be more than 25 millimeter of mercury. And this idiopathic intracranial hypertension is one of the diagnoses of exclusion, and the etiology is still not well understood. Okay. So what are the various medical management for this patient? First is weight loss and a cessation of medications like OCP, and third is acetazolamide. Acetazolamide tablet, which is the acetazolamide reduces the CSF production. By the way, the patient will the ICP will be reduced. Okay. So weight loss, cessation of the medications like OCP. So the OCP, which is a thrombotic agent. Okay, it will cause sinus thrombosis. Okay, and it obstructs the venous drainage, so that the ICP will be reduced. So that you have to stop the OCP drugs. And acetazolamide, it will reduce the CSF production. Next, what are the surgical conditions? The surgical condition, you have to go for VP shunt or lumboperitoneal shunt. Number third is optic nerve sheath fenestration or venous sinus stenting in selected cases. These are the various surgical options. So the surgical option is, the main thing is here go for a lumboperitoneal shunt, LP shunt, VP shunt. The main indication is visual field loss or visual failure despite medication. Okay, the indication for this procedures. And more minimally invasive, we can go for optic nerve sheath fenestration, okay, or venous sinus stenting, okay, to encourage the venous drainage, okay, in selected cases. This 35-year-old male presented with a progressive headache with the vision loss. Okay, so what is the diagnosis here? Here you see the one hyperintense lesion in the MRI, okay, and with the enlargement of the ventricles. Okay, so it shows that the patient is having some obstructive hydrocephalus due to mass. Okay, especially in the region of the third ventricle. Okay, and it typically looks like a pineal region SOL. Okay, and the fundus of this patient, it shows papilledema. Okay, so what is the diagnosis here? This is a case of obstructive hydrocephalus due to the pineal region SOL. Okay, so what is the fundus finding here? It shows papilledema. And what are the gradings of the fundus? It's given with the Friesen grading. And what are the various types of hydrocephalus? Other types of hydrocephalus, okay, we will see later. That is obstructive, non-obstructive hydrocephalus are present. Okay, and various treatment options for the hydrocephalus. First, this answer is the obstructive hydrocephalus due to the pineal region SOL. Okay, the fundus shows papilledema. So the papilledema will be graded by the Friesen grading. It is Friesen grading. It has 5 grades: grade 1, 2, 3, 4, 5. Okay, so grade 1 is showing grayish C-shaped halo surrounding the disc. Okay, this is C-shaped halo surrounding the disc, and this sparing of the temporal margin and radial nerve fiber striation distribution. So the grade 1. The grade 2, the halo becomes circumferential. Okay, the halo becomes circumferential and the nasal border is elevated. Okay, and there is no major vessel obscuration. The grade 3, obscuration of at least one vessel. Okay, leaving the disc. Okay, see, the obscuration of the vessel and the elevation of all the borders, and there is circumferential halo. It's grade 3. Okay, okay, it's the grading of fundus grading. Okay, for the papilledema given by the Friesen. Okay, the 5 grades: grade 1, 2, 3. The grade 4 is obscuration of the major vessel. Okay, and it involves cupping. Okay, cupping of the optic disc. Okay, and he is also having circumferential halo. Grade 5 is showing obscuration of all the vessels. Okay, all the vessels on the disc are leaving the disc. Okay, especially the veins leaving the disc also is obscured, and the inside also is obscured. Okay, with the features of grade 4. Okay, so Friesen grading is 5 grades: grade 1, 2, 3, 4, 5. Okay, this varies with the presence of the elevation of the borders. Okay, and presence of the halos around the disc, and vessels, obscuration of the vessels around the disc. Okay, 1, 2, 3, 4, 5. So what are the various types of hydrocephalus? Obstructive hydrocephalus, communicating hydrocephalus, and the hydrocephalus due to excessive CSF production. Okay, and the obstructive hydrocephalus, whenever there is a lesion in the ventricle or ventricular wall or lesions distance from the ventricle, this is a mass effect. Due to the mass effect, the communicating hydrocephalus, especially of post-hemorrhagic CSF infections like TB, meningitis, and raised CSF proteins and excessive CSF productions due to choroidal plexus papilloma or carcinoma. There is a treatment options for VP shunt where the various treatment options for your hydrocephalus is VP shunt, endoscopic third ventriculostomy. Okay, then is temporary measures we can go for external ventricular drain. Okay, these are the various VP shunts. Okay, various types of VP shunts and used. Okay, so this is a typical case of obstructive hydrocephalus due to the pineal region SOL, and the patient showing papilledema. Okay, these are the Friesen grading for the papilledema and the various types of other hydrocephalus and the treatment options for the hydrocephalus. Next, a 15-year-old boy with a traumatic brain injury present with a CSF rhinorrhea. Okay, he is admitted in the ward for conservative management with antibiotics for 2 days. After that, the patient suddenly develops severe headache, fever, neck rigidity, and the neurosurgeon examined the patient and in which the following test shows positive result. Okay, so what is his test he is doing, and what is the diagnosis of the patient now, and what are the other tests to elicit this diagnosis? These are some basic questions. So what is the test he is doing is Kenning's test. Okay, So the diagnosis is the patient developed meningitis. Okay. Post-traumatic meningitis he developed. Okay. And the other signs to elicit the meningitis is Residency sign. Okay. So these are the signs used for the meningitis. The Kerning sign. The Kerning sign, the patient you keep in the supine position with the hip plus to 90 degree. Okay, with the hip plus to 90 degree, but the knee cannot be fully extended. Okay. When we try to extend the knee, the patient screams of pain. Okay. So the Kerning sign, the knee extension is painful. It shows that the patient is having meningitis. Okay. The knee extension is painful because of the meningeal irritation. Next is Residency neck sign. Okay. In this, what to do? Whenever you have to passively flex, okay, the neck of the patient, it causes flexion of both legs or thighs. Okay. It is called Residency sign. Okay. It is positive in meningitis. Okay. And you also feel a neck rigidity also. Okay. So the Residency sign, whenever there is a neck flexion, it also leads to a knee flexion. Okay, these are the two important signs that we use to elicit the meningitis. One is Kerning sign and another is the Residency sign.